thank you so much for joining. Welcome. My name is Diana Arias with the Community Technical Assistance Center at the NYU Silver School of Social Work's McSilver Institute. And again, I want to welcome you to today's offering, ADHD, PTSD, or both, Exploring Best Practices for Children Exhibiting Comorbid Symptoms, presented by Dr. Michelle Ferrer. Before we get started, I do want to orient folks so you know how to participate in today's event. This is a Zoom meeting, but upon joining us, you have been placed on mute just to avoid any background noises that may distract others from listening to the presentation. If you come across any issues, any tech issues, please chat into the host who will be able to assist you. We will be having a Q&A portion toward the end of the presentation, but we do ask that you submit your questions at any point during the presentation via the chat box. At the end of the presentation, there will be a survey that will pop up, and we do ask that you take a moment to fill that out, as your feedback and suggestions do help inform our future offerings. Also, the recording and slides for today's presentation will be posted on our CTAG website within 2 to 3 business days, along with the resource created by today's presenter. Great. So on behalf of the Community Technical Assistance Center at NYU, Silver School of Social Work's McSilver Institute, I want to welcome you all. We are very excited to have with us Dr. Michelle Ferrer, a bilingual English-Spanish licensed clinical psychologist in Florida, working with infants, children, adolescents, and their families. I do again want to thank you all. I'm going to turn it over to Dr. Michelle Ferrer to get us started. And if you didn't get the link to the survey, please feel free to do that as well. I know some of you people were trickling in, but nonetheless, Dr. Ferrer, thank you so much for joining us.
So thank you for having me here today. My name is Michelle Ferrer, and I'm a licensed clinical psychologist in Florida. I obtained my PhD in clinical psychology from Yeshiva University, then completed child fellowships at UC San Francisco, Hackensack Medical Center, and did a lot of my training in New York City as well. So I currently work in private practice in Florida using culturally attuned psychodynamic treatment with infants, toddlers, children, adolescents, and their families. I'm the current co-chair of the Diversity Committee of the Florida Psychological Association. I'm a former lecturer of the University of Miami and former diversity delegate for the American Psychological Association. My interests include the intersection of psychodynamic theory, childhood trauma, and diversity. So before we get started today, I wanted to ask you all through the chat, what are the major concerns that you have at this time about the diagnostic criteria of ADHD and PTSD in children?
So we have a few things coming into the chat box, Michelle. It seems certainly the overlap or the misdiagnosis or the underdiagnosis or not considering PTSD with relation to ADHD is what I'm seeing.
Perfect. I mean, not perfect. It is a problem, but we're all on the same page here. And these are a lot of the questions I had as well when I started doing this kind of investigation of, what is going on. So I originally became interested in this topic of understanding the similarities and differences and what everyone's talking about, this misdiagnosis, overlap. What could this mean? I started coming across that during my clinical training for my PhD in clinical psychology. I trained in many community mental health clinics, actually a lot in New York City. And I started to realize the majority of children and adolescents I was seeing were presenting with externalizing behaviors that were being diagnosed as ADHD by psychiatrists, previous therapists, school systems, or even by self-report sometimes. And when I started working with these children, I quickly realized that they had been exposed to so many different environmental stressors. So then I began wondering if their externalizing expressions of symptoms were more in line with PTSD, which would require a completely different treatment plan altogether. So I started doing some literature searches in 2016 or so and realized there was not a lot of information available in terms of research to understand this overlap. So I started to kind of create my own way of assessing using evidence-based practices and utilizing therapy, different types of therapies to see what would be helpful. And so that's what we're here to discuss today, to help us understand how to tease apart these symptoms and how to best manage them. What our conversation today will be that kind of like a conversation. I'm kind of thinking about this in terms of a little bit like a supervision within a huge group. But I want there to be feedback, conversation, discussion. If there is a particular case that this resonates for you with, that's great. We want to apply these kinds of techniques. So if there's a particular case or new referral that you just obtained that you want to kind of think about as we're considering these techniques, even better. After we finish here today, I hope that you all have a better understanding of the overlap of these symptoms of ADHD and PTSD and how to better tease them apart. But more than that, though, I want to help us reflect and think through how behaviors have meaning and what they might be telling us on their own, separate from anything of any way we might label them, whether it's ADHD, PTSD, anything else, really reflecting on behavior. And like we've kind of mentioned here today, this topic is relevant and important because PTSD and ADHD share so many similar symptoms, and misdiagnoses can occur if they're not well understood. Sorry. Okay. So before getting into the similarities of PTSD and ADHD, I did want to provide a brief background of PTSD and ADHD on their own. So we're going to be thinking about childhood trauma first, and it can manifest as so many different diagnoses, whether it be adjustment disorder, acute stress disorder, reactive attachment, PTSD, and now even more research is solidifying the need of a separate diagnosis for complex PTSD. For today, we'll be talking a lot about PTSD in general and its criteria, but it's important to know that even though children have gone through a certain trauma, they might not have the types of reactions that might map onto a diagnosis of PTSD. So it's important to be flexible in how we think of behaviors. So regarding PTSD, it's a set of criteria that children can develop after being exposed to perceived dangers or threats to safety. And traumas can be isolated events, which might be the case with a singular natural disaster, a motor vehicle accident, an acute medical trauma. So if we're thinking about just a singular trauma, in this scenario, a child has a relatively stable perception of safety, and it's kind of a baseline. There's a natural baseline for danger is relatively stable over time until an acute event changes that view of safety. So there's like a dip in their understanding of safety. And then our goal is to kind of get the child to feel back in their baseline, to help them get back up. So most of these isolated situations, we have that baseline, we see that dip, and then our goal is to help us get back to baseline functioning. A lot of these isolated experiences are not necessarily involving interpersonal relationships. So it's important to recognize that the child's view of danger is not necessarily intertwined with relationships. It's more of this particular event. However, there are other forms of trauma that can be continuous. So they happen over and over at different points in a child's life. So if we're thinking about that idea of having a baseline, if a child experiences continuous trauma at a very early age, the child will not have that healthy baseline because their baseline is kind of going up and down and up and down. So it will be continuously unstable. And even if they did have a stable baseline at some point, if a child keeps experiencing these continuous stressors in their life, their sense of safety will start to erode and they will not be able to sustain like that healthy baseline or come back to that healthy baseline that easily. And so that is what tends to happen with continuous or complex trauma. And some of these more complex events include things like war, poverty involving insecurities related to food and housing, exposure to violence, whether that's in the community or interpersonal violence at home, sexual or physical abuse, neglect, or immigration. So it's important, like I said, that not every child exposed to traumas will meet criteria for PTSD because it might manifest differently, being that these are it's not the same thing as having this baseline and then having an isolated event. And this is a continuous thing. So things might manifest differently in kids. And that's why there's a big push now to consider complex PTSD as a separate diagnosis. So I've included here immigration as a continuous or complex trauma. Some people might consider it more of an isolated event, but I want to think through with you what might be some of the things that might make immigration a complex trauma. Mhm. Right. There's so many different things that are being posted in the chat that um, are all very true, that children can experience all of these different things, and it's can be complex. There's so many different experiences that are related to immigration. It's not just the process of I am coming to a new country and I'm maybe you know traveling to that other country. I think of it as there's the traumas in the home country. So a lot of times families leave their home country because of civil war, low resources, community exposure to community violence. So a lot of times kids that have gone through immigration have a history of exposure to trauma in their home country. Then they have the actual traveling from their home country, which a lot of you mentioned separations from family, right? Also, sometimes it's not safe having to travel from their home country. There's a lot of hiding. So whether that's hiding physically or hiding your identity, sometimes kids come with new papers that show different names or ages that they're used to, creating this new identity of who they are. Then you have living in a new country, which has issues of acculturation. Again, these limited resources, language barriers that might impact their ability to get resources. Racial trauma or discrimination. And we do know now that racial trauma can negatively affect physical, mental, and emotional health. I mean, we've always known this, but it's becoming more heavily studied now that we have data to support it. And these issues can lead to PTSD and other trauma manifestations. Now, it's important to note that a lot of these continuous traumas generally involve some interpersonal dynamics. Therefore, manifestations in behavior might include changes in trust and safety with others. And that's a pretty big component of a child's worldview of safety at that age. Glitching. Okay. So who here has heard of the ACEs study? Some of you, great. So traumas generally have this ripple effect that impacts individuals in many different ways. And a group of researchers in 1998 wanted to know how childhood trauma could affect adults. So the CDC and Kaiser Permanente conducted a study on adults. They asked the adults to go back in time prior to their 18th birthday and mark which of these several adverse experiences they had personally gone through. Then the researchers took that information and looked at participants' health to see if there were any correlations between health and adverse experiences. What researchers found was that the more adverse childhood experience someone was exposed to, so the higher their ACEs score, the higher they said yes to these questions, the more likely they were to have higher levels of chronic health issues later on in life. So for example, participants with a score of 4 or more, meaning that they experienced 4 or more of the traumas listed here, were twice as likely to develop heart disease. And a score of 7 or more, they were 3 times more likely to develop cancer. So researchers have concluded that trauma and adversity in childhood raises the risk of numerous health issues, such as diabetes, heart disease, cancer, and mental illness later on in adulthood. So we just discussed some of the ways in which trauma can impact adults later on, but I wanted to open it up to the chat to see other ways you have seen or can imagine trauma can impact children in these functional domains. So what ways have you seen?
So a few things that are coming in, dysregulation, difficulties managing behaviors, dissociation, hyperactivity, impacting sleep, school avoidance, attachment issues, depression, fear.
So it can look like a lot of different things. Everybody's different. Individuals are all different in how they express their exposures, their feelings in response to exposures to trauma. So it can really look so different. But a lot of you are posting very good and very different. I think that's the main point here, that they are very different presentations, that there's no one size fits all, and it affects so many different parts of a child's life. So here we have a diagram looking at the different ways that trauma impacts children. And I wanted to take a step back to think about what are some of the symptoms you see here that coincide with ADHD. I don't know if you can you see I know it's pretty small. Oh, wait. Mm-hmm. Right, a lot of impulsivity, emotional regulation, hyperarousal, impulse control, academic. Right. So the hallmark presentations of ADHD are here in the impact of trauma. That makes it very confusing when we see just a child's behavior, because on the outside, it doesn't tell us a whole lot, but we're kind of formulating this understanding of what is this behavior. And then it does meet criteria in a lot of ways for these two things. So regarding physical health, we just spoke that trauma and adversity in childhood raises the risk of health problems in adulthood. But if we focus only on children, adversity's impact on health could include a poor immune system due to chronic cortisol and sympathetic nervous system arousal. Children could also have issues with sleep, maybe from being too scared to stay asleep, or due to recurrent nightmares. They could also experience difficulty eating. Some children may develop selective eating habits as a form of control, or some may experience difficulties recognizing the hunger in their bodies, or maybe they just don't feel hungry if they're in a constant state of arousal and anxiety. So if children aren't sleeping well, if they're not eating well, it just makes sense that even just taking that into context, that could really impact their behavior and their presentation. We also know that emotionally, children exposed to trauma show difficulties in the identification and regulation of strong emotions. So if they're constantly experiencing high levels of stress, they're going to be more prone to difficult emotions and maybe become easily overwhelmed and dysregulated. This is sometimes the case when children have ongoing interpersonal traumas, in which their caregivers might exhibit difficulties in attuning to their needs and mentalizing what their child is feeling. So in healthy, secure attachments, children recognize their sense of self and start to build their sense of self through the reflection and mentalization of primary caregivers. So if a child is crying and that experience is validated and mirrored through a parent and made sense of with that parent, the child begins to develop the understanding that I have my own thoughts and feelings and beliefs, and they're important, and they're being recognized by other people. And that in turn is this like dynamic in which it increases their own sense of self, their own sense of autonomy and control in the world. So this method of learning through oneself, through those interpersonal relationships, has been studied and understood by attachment experts like Bowlby, Fonagy, Klein, to name a few. And that's why interpersonal traumas are particularly difficult, some of these complex traumas, because they have the ability to impact emotional and relational functioning in children. And a lot of times families, when they're going through high levels of stress, they're not really afforded the time, energy, or perhaps have developed their own skill set to engage in that type of attachment. And that continues to impact the child when they go on to have to form their own attachments in the world and other interpersonal relationships. In terms of behavior, trauma affects external expressions of regulation, like impulsivity, acting out and aggression. I know a lot of you posted that in the chat as being one of the things that are look a lot like ADHD diagnostic criteria. Research indicates that issues with attention and PTSD is likely a combination of the child's increased arousal and compromised inhibitory functions, not being able to shut certain things off. So behaviors could manifest also as internalizing problems that look like withdrawal and avoidance. Cognitively, children exposed to recurrent traumas are maxed out, and they're constantly what Dr. Daniel Siegel calls flipping their lids. Has anyone ever heard of Dr. Daniel Siegel or any of his work? Great. So what flipping their lids mean is this is something coined by Dr. Daniel Siegel, and I'm going to make a model brain out of my hand. And we have here the prefrontal cortex of the brain, which is right here. This is where we do a lot of thinking, planning, and organizing. It's where we integrate a lot of our executive functions. Then in the middle of the brain, internally, we have structures like the amygdala and hypothalamus that respond to emotional content, and those are inside. And they're readily involved in the fight, flight, freeze autonomic system. The thing is that when a structure like the amygdala is turned on, and this is on, it causes the prefrontal cortex to shut off, and it kind of flips what Daniel Siegel calls flips the lid, which basically means once we're in this fight, fight, freeze survival experience, we can't do much of thinking or organizing because we're primed to get to safety. And something not traumatic, but something that happened to me that really showed me how this worked in my own body is that one day I was actually, I was swimming, I was snorkeling, and I came across this 5-foot shark. And for a split second, I was just in awe. I was like, wow, I've never seen a shark before. This is amazing. And then something just clicked inside of me. It wasn't even a second later. I had this impulse in my body to just get out of the water. And it completely shut any logic off of, you probably shouldn't splash in the water. You're probably better if you just stay still and keep looking at the shark. All of these logical things kind of came out, and I had an impulse to just get out. So even though I logically knew sharks are not that dangerous, my impulse caused me to flee right out of the ocean and when I saw a perceived threat. And so that's what happens to children. When they experience a threat to their safety, whether it's happening now or something that happened in the past, that impulse inside their bodies just overpowers their logic, and it becomes hard to control. It becomes so hard to focus then, learn at school, concentrate. It also becomes just hard to keep up developmentally with other kids. Okay. So we're quickly going to look at the diagnostic criteria of ADHD. So ADHD is a neurobiological diagnosis that explains behaviors that children exhibit. So the condition is explained by certain neurobiological changes in attention and impulsivity, but the etiology of it is still mostly unknown. Current recommendations or diagnostic evaluation of possible ADHD include the observation of multiple specific behaviors in different settings, getting a comprehensive history, and knowing more about the child's school performance. The treatment of ADHD is mostly focused on behavioral management and medication management, aimed at increasing executive functioning and pro-social skills. Management can come in the form of parent training, teacher or school behavioral management, reinforcements for the child, but both the medical and the behavioral interventions are considered symptomatic treatments, meaning they are trying to just stop or decrease the symptoms. So since ADHD requires symptomatic treatment, it's placed in a similar category as other chronic conditions like diabetes or asthma. But the problem with ADHD being a symptomatic diagnosis is it does not allow us much room or space for processing, exploration of feelings or thoughts, which can yield sometimes deeper results than just kind of trying to make the behavior go away. So we have here a vignette showing the DSM criteria for ADHD and PTSD. And though we can appreciate their, respective differences in each circle, the ADHD symptoms in red, PTSD in yellow, the Venn diagram shows that they share certain symptoms pictured here in brown. And it's interesting because just as we looked at the other diagram, the symptoms we would actually consider hallmark ADHD symptoms lie here in the middle with PTSD. So, of course, we need to be cautious when evaluating and treating children to ensure that they're receiving the appropriate care that they need. The link between ADHD and PTSD is now being studied more seriously, and there's more research trying to understand these comorbidities. For example, research has shown that deficits in attention and prefrontal cortical function, resembling people with those that have ADHD, have now been identified in people with PTSD as well. Additionally, there's a bidirectional relationship that exists between trauma-related disorders and ADHD. So one can kind of predispose the development of the other, and they can worsen the severity of the other, and it kind of works bidirectionally. Other research indicates that children with ADHD who experience a traumatic event later on are 4 times as likely to develop PTSD criteria than children without the disorder, and they're more likely to have more severe symptoms. So what I want to do now is I want to kind of go through this typical yet imaginary vignette of a new case that might be presented to you. So this is a case that I created through different stories of several different patients I've had over the years. And I want you to imagine, apply this to a particular patient you might have had or may have. And even though we have limited information, let's just assume that these are the major problems that are getting reported to you by a parent. And as we kind of go through this, I'd like you to know on your own what symptoms you see are indicative of ADHD, and then what symptoms you see that are indicative of PTSD. So Tiffany is an 8-year-old Black girl referred to a community mental health clinic by her mother, Lisa. Lisa indicates Tiffany is not doing well in school and is being constantly reprimanded for not listening to directions. Lisa reports that teachers believe Tiffany seems to be purposefully doing other activities and avoiding class assignments. Lisa says she understands what they mean because she also notices Tiffany daydreams often and doesn't seem to be engaged. Lisa reports Tiffany enjoys spending time on her iPad after school, but gives Lisa a hard time when asked to finish her homework. Lisa explains Tiffany has been this way since she started school in kindergarten. She reported that since then, Tiffany did not want to go to school and would cry for several minutes at drop-off before engaging in individual play with a specific interest that harnessed her attention, such as dolls. Lisa says drop-offs have improved somewhat since then, but recently noticed Tiffany crying in her room alone. But when asked what was wrong, Tiffany shut down. When you meet for the first time, you start by explaining the therapeutic process, and Tiffany barely makes eye contact before excitingly picking out toys to play with in the clinic room. Lisa sighs and explains she never likes to listen and just wants to play. So I want to take a look at this new referral and just kind of think through just for a moment. Take any notes that you need to. And I can bring it back every so often if necessary. Or you can actually, I don't know if you can copy and paste, but we'll be going back to it throughout the discussion. Before we continue though, I want to know, what do you see first? A lot of ducks. Yeah. Yep, there's a duck, and then there's also a rabbit. You kind of have to change your lens a bit. And then I'm going to show you this, cognitive phenomenon. It's called the McGurk effect. You're going to have to be looking at the man's mouth. So pay close attention to the man's mouth. And I apologize in advance for the consistent noise you will hear, but it has a reason, I promise.
Ba 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 ba.
Okay. So could everyone see the differences in the man's mouth and the changes and what it seemed like he was saying? Great. So I'm sorry. I know that it was a lot of the same noise over and over again. It was the same sound. That's right. I'm trying to move to the next slide. Okay. So the reason I put these different kind of cognitive illusions or different illusions is because they're shown here to emphasize to us that we can change our lens and how we see the same information from different perspectives. So the behavior of a child will stay the same no matter what, whether we use the neurobiological lens or trauma lens. But the more flexibility we have in attending to the different lenses in which a child shows their behavior can help us understand the child better and make sure that they're receiving the treatment that is required for their needs. So we're we're going to be kind of going through these lens shift, the shifting in lens. And we're going to be thinking about, what it looks like for ADHD. What does it look like for PTSD? So, okay, for ADHD, what are some symptoms that align with ADHD? Task avoidance, daydreaming, distraction, inattention, low interest. Yes, for the specific case related to Tiffany. We're going to go back and look at, the notes that you might have taken to see what symptoms map on to ADHD. Hyperfocusing, right? You're wondering, yeah, low self-esteem. You're wondering if that could be, yeah. Great. So a lot of the symptoms can seem to be ADHD. And then what kind of symptoms align with PTSD that you saw? Crying, dissociation, avoidance, withdrawal, separation anxiety. So the same behavior of not listening, not following directions, when we think about it for ADHD, we think of it as inattention. And when we think about it for PTSD, I hear a lot of avoidance or withdrawn. And it's the same behavior, but it's that shift in how we're in the lens through which we're seeing it. Great. So the reality is that a lot of these symptoms actually do fall into both categories. They do meet a lot of the criteria, maybe not the full criteria of the diagnostic, criteria, but it does meet a lot of the symptoms. So it's important to recognize how each symptom, let's think about how each symptom might fit into the presentation of PTSD, since these symptoms are typically representative of ADHD. And what type of ADHD do you imagine this might be representative of? So that we have the attentive, inattentive, the combined, yeah. So I wanted to purposely consider a vignette featuring internalizing behaviors and inattention, because when we tend to think of ADHD, we think about them a lot of times for externalizing behaviors. But it's possible for children with traumas to also be diagnosed with ADHD inattentive type, since they might meet criteria for both. So I want us to consider, in Tiffany's case, how might not listening or avoiding schoolwork in the classroom be a symptom of PTSD? How might that show up? Avoidance, escaping, hypervigilance. So not being able to stay focused because they're hypervigilant to something else. Dissociation. Maybe something is triggering and this Tiffany wants to isolate and feel safer. Yeah, so these are all true. We can think of these behaviors in different ways. And it's like some of you mentioned, some of the behaviors could be present because maybe Tiffany is just maxed out looking for safety cues in her environment. So like we previously mentioned, children might be hypervigilant looking for danger. And that's one of the ways that trauma can manifest, trauma behaviors can manifest. So Tiffany might, maybe one, not be interested in paying attention to a math lecture or able to pay attention to certain directions from the teacher, like take your backpack with you, because she's, too focused on other things that are more important for her. Or she might just be so overwhelmed by all these different thoughts and feelings in her body that she's kind of protecting herself by shutting off her mind a bit, to just take a moment because it just feels so overwhelming. And maybe that's when she misses the information that teachers are recognizing she's not getting it. Additionally, she could be having flashbacks in that moment and could be completely disoriented because it just feels like that trauma is happening in that moment, even though it's not. She might be dissociating and kind of feeling like she's somewhere else. Right. Also, another way we could consider these behaviors is, teachers thought maybe she was doing them on purpose. And let's imagine that might be true sometimes. Tiffany might be doing them purposely for some reason. Again, we could consider this to be kind of not following directions of PTSD. But what might it mean if she had been exposed to a trauma? Why might she purposefully not do things correctly? Mm-hmm. Control. Maybe she's having a trigger of a trauma and doesn't feel safe and wants to act in a way to make herself feel safe. She might feel like I'm constantly doing things wrong, and now what's the point? Purposefully doing things wrong to actually get out of school because maybe she doesn't feel safe, right? Maybe it's a cry for help. Maybe she wants people to know she's not doing okay. Yeah. So when a child like Tiffany is building their worldview of safety, especially in interpersonal relationships, if these, chronic continuous traumas are happening, they often test people to see how they will react if they're not doing the right thing. If other adults have hurt them in the past, they might want to see, are you safe? So they might test people as they're learning what is safe, what is not safe. Tiffany might wonder, what happens if I don't do this? How will people react? Are they safe? In some extreme cases, sometimes the anxiety and loss of control of not knowing who is safe and who is not safe and what is considered safe is really disorienting and dysregulating, and children just cannot handle that. They act out and they want to have more control over the people getting upset with them. In addition to all the other qualities that you all have mentioned. So we're going to be thinking about how to apply these lenses during the assessment, treatment, and monitoring progress throughout working with children. So one of the first things is we want to make sure that we start assessing behaviors and symptoms and gather as much information as we need and as we can from a variety of techniques. So clinical interviews, standardized measures, behavioral observations, and getting a variety of different perspectives. So from the child, caregivers, teachers, the CASADS, which is the Kitty Schedule for Affective Disorders and Schizophrenia, is a good structured clinical interview if you ever needed one. But for this vignette, let's imagine Lisa, the mother, completed an intake prior to the first meeting in which she discussed in more depth the presenting problem of inattention, but made no mentions of traumas or difficult experience, and similarly with the teachers. So you're kind of starting from scratch of like, you know, there's no obvious traumas being reported. What we'd like to do, in addition to a good clinical interview, is make sure we include a measure of trauma in our intake. So here's a list of different trauma measures you can use for different age groups. Something like the CBCL gives us important information about behavior, but again, we have to keep in mind behavior is representative of different things. So we also want to use a trauma measure. So some trauma measures will have rating scales for diagnostic criterias. Others might have questions about exposure to a particular trauma. So even when asked directly in age-appropriate terms, sometimes children and parents don't endorse exposure to traumatic experiences. Why might that be? Shame, denial, not aware, the stigma, fear, guilt. It might feel normalized for them. Yeah, these are great, great thoughts. And it's right. There are many feelings involved with the disclosure of difficult events, especially if it's intergenerational. Many adults and children, especially those that have experienced child protection service involvement or other agency involvement in the past, might not want to talk about trauma or explore traumas, especially occurring at home, because they might be fearful of family members getting in trouble or worried about being separated, or there might be shame or other feelings associated with it. Additionally, parents might not even consider the impact of adverse stressors on their children because they themselves have grown up in similar situations that they're not considering something as traumatic. That's just kind of, like someone said, normalized. Also, children may not be able to communicate the ways in which past traumatic experiences have affected them. So it's hard to identify experiences right away at intake and maybe take some time to build that trust. So the important thing to note is that even if a child and a parent doesn't endorse adverse experiences, we should not conclude that the child has not experienced something traumatic or some adverse experience. So let's imagine we give the age-appropriate trauma measure to Tiffany and a parent version to Lisa, and they don't endorse any traumas. Again, it doesn't necessarily mean that Tiffany has not been exposed to trauma, and we should continue exploring her symptoms. What we then want to do is create a timeline. So in the case of Tiffany, Lisa reported symptoms started in kindergarten. So let's say it's roughly 2 years ago. It would be helpful to get a history of Lisa's behavior from teachers, Tiffany's behavior from her mother, teachers, medical professionals that have known her before and after, to see if there was some kind of gradual change or was it sudden. So children with ADHD usually demonstrate increased sensitivity at an early age, and these behaviors generally worsen and become more complex that usually impact school functioning. With PTSD, we might expect to see a sudden change in symptoms, which is a good way to kind of recognize them. However, if the child has been exposed to chronic trauma from a young age, like we talked about before, that baseline is going up and down in functioning. So we can't really say, you know, if it was something gradual, it could have also been just increased challenging events early on in a child's life. So in the case of Tiffany, we know that her behavior started in kindergarten. And I might ask Lisa things like, you know, if Tiffany had other issues at separations before going to kindergarten, like at daycare or with babysitters. Lisa said Tiffany sometimes seemed pouty when she had to leave for work, but overall didn't scream and cry like she did in kindergarten. Tiffany's kindergarten teacher was able to be contacted, and she reported she remembered Tiffany had issues with separation, but 1 week in particular, things really escalated and the rest of the year became a struggle. Now, I don't have absolute information, but I'm starting to sense a pattern that even though Tiffany struggled with separations, somehow the behaviors escalated a bit midway into kindergarten. And that's still not enough to determine, the diagnostic criteria, but we're getting to understand more patterns. And that's the point of doing this type of work. We want to understand patterns. So another way to understand child behavior is to recognize the external expressions of it. So we can try to identify the antecedent to a behavior and the consequence of a behavior in collateral conversations with other teachers, parents, providers. So for example, we can talk to Tiffany's teachers, and that when they let us know that Tiffany has difficulties following directions, like maybe not picking up her lunchbox at lunchtime, and we can ask the teacher if she remembers what Tiffany was doing before being asked or what Tiffany was doing after she was asked. We can ask the teacher to keep in mind to look for antecedents and consequences using this model, and explain the purpose of understanding the sequence of behavior so that we can understand the behavior more deeply. We can also utilize this approach in therapy. So let's say we better want to understand Tiffany's behavior of daydreaming. So in sessions, I would really be looking out for that kind of behavior. I would be staying very present and aware of her behaviors and what's kind of coming before and after. So the antecedents and the consequences. And during one of our early sessions, let's say in the middle of playing dolls, I recognized Tiffany looked out into space and seemed lost in thought. Kind of like that daydreaming quality that her parent and teacher were talking about. At this point, I don't engage her in the pro-social behavior, like, hey, listen to my story. We're talking about dolls. What happened? Instead, I wonder, what just happened? Like, what happened that she stopped playing and looked at the door? I then realized at this time I could hear footsteps outside the clinic room. And I began to wonder if that's what got Tiffany to look as if she was daydreaming. I then continued to wait to see what Tiffany does after she engages in this type of behavior. Tiffany, in this moment, started to look around, and then she just got up and left the room, and she went to go look for her mother in the waiting room. So now I have more information about this behavior. It might be tied to safety. I would continue to monitor this and other presenting behaviors over time and on separate and varied occasions to see if I can uncover more patterns. But over time, I recognize that Tiffany's experience of daydreaming seems to happen in a reaction of hypervigilance. And while that by itself doesn't give us necessarily the criteria again, it does give us more information to understand her levels of safety. Okay, another way we could assess behaviors is to understand what the behavior is telling us from the inside out. So until now, we've just been looking at behaviors mostly. We've just been kind of seeing the outside, but there is so much more inside that the behavior is telling us. So trying to understand the child's inner workings is so important. We can work with the child to understand the thoughts and behaviors, thoughts and feelings behind behaviors. For Tiffany's case, let's consider her behavior of crying, especially at drop-offs. Now, crying can come with many different thoughts and feelings. So we should be careful not to assume crying means sadness and it means this and it means that. We want to leave it open. There's like this range. We don't want to ascribe all these different things of, oh, it's because of this, it's because of that. But we also don't want to just ignore all these different behaviors that might have rich information to them. So we want to keep it open. At the same time, we want to be inquisitive. So, let's imagine that for this particular instance, we ask Tiffany why other children might cry at school. Maybe she doesn't know. We ask her, why do you cry at school? And she's like, I don't know, like most kids kind of do. So we might ask, why might other children cry at school drop-offs? What do you think they're feeling? And she might say something like, they might be scared. They don't know if the mommy is okay. And so in that example, for Tiffany, crying it seems to be related to maybe expressing fear. And then the thoughts that might be going along with that are thoughts about separation and loss of some sort. And it's important to consider repeated patterns related to safety and danger and loss that might be indicative of PTSD symptoms like intrusive thoughts, hypervigilant, cognitive distortions of the world or safety. So over the course of our time of starting therapy, In several sessions, she starts to discuss crying and play, and in the context of missing mommy. So if a child has been exposed to any adverse experience, or you suspect they have even a little bit, a good rule of thumb is to integrate trauma-informed treatment in addition to any ADHD treatment. Sometimes they could be different because, like we mentioned, ADHD treatment is kind of pro-social behaviors, like behavioral management. We're telling the child not to do certain behaviors. Trauma, and especially psychodynamic trauma-informed treatment, is more allows the child to be more expressive. So it's the goal is to also help the behavior, but we're not just going to, say you have to do this or else, because that's what the child is getting everywhere. And this needs to be a space where we can explore it. So we can use a treatment that is suitable for both diagnoses and monitor over time to see the progress. And it's important to note when conducting trauma work, progress is not always linear. It's possible symptoms might worsen because you're breaking down certain defenses or working through difficult material. Also, monitoring can be done in the same fashion as our initial assessment process, kind of going back and thinking about all these different things again and repeating that process, and maybe using a behavioral checklist as well. It's also possible that if active adverse experiences are currently happening, the child's behavior will likely continue. So in that case, the goal wouldn't necessarily be to decrease behavior, since they're telling us something about the environment and the child's reaction to the environment. But then we can work with the child's environment to see if we can change certain aspects, whether that's parental stress and reactivity, maybe custody disagreements that are happening in the child's life, or bullying at school, whatever it might be. And we can do that through trauma-informed evidence practices. So Tiffany's case is a very common. We're still, at this point, we've done a lot of assessment and a lot of work, and we're still not quite sure if she's been exposed to trauma and if her inattentive symptoms meet criteria for PTSD, but we do know that Tiffany's behavior changed substantially in kindergarten. She engages in dissociative behaviors when she's scared. We know she worries about the safety of others, particularly her mother. And while we might not have enough information to diagnose PTSD, we can still treat the patterns and behaviors, like the feelings about separation and loss, through a similar model, just not applying it to a particular trauma that the child has expressed. And at this time, probably Tiffany would meet criteria for ADHD and attentive type, but in our documentation, we could also emphasize our concern for trauma exposures and use treatment that can address both diagnoses, or diagnose with a different type of trauma reaction that would allow for the appropriate treatment. Okay, so what I want us to do is to now think of this vignette. You will all go into breakout rooms in just a moment. And even though we have limited information, I want us to use the same techniques we just applied in recognizing how the symptoms might be representative of PTSD. And we might not have all the answers, just this is a vignette, but I want you to consider a patient that you have either worked with a similar presentation, or apply with someone that you may work with in the future, and considering all this information. So you might, fill in certain answers with the patients that you've kind of worked with or may have an understanding of. There's no right answer. And that's a good thing, because that's what happens with behavior. We don't know, and nobody has the right answer. We're trying to understand the potential meanings together, at least today, together, and then you on your own, in your own agencies. So it's okay if you fill something in, or if there's a gap in knowledge. We're not going to have all the information. I just want you to be creative. So this is the vignette. Sebastian is a 7-year-old Hispanic boy referred to treatment at a community mental health clinic by his 2nd grade teacher. The teacher reports he recently joined the school mid-year, and he does not listen in class, leaves the room without asking, is not following directions, and has threatened other students with violence. For example, the teacher notes Sebastian pushed another boy in the class because the boy took a drawing that he was working on. She says Sebastian has a particularly difficult time in class during quiet activities like reading. She explains that during quiet seated activities, Sebastian paces the room as if looking for something, but she believes he's just getting out of work. She says the only thing that helps Sebastian settle down during these activities is to work one-on-one with a teacher. The teacher believes he might have ADHD and is hoping therapeutic services can help change some of these behaviors. When you meet the family for the initial intake, you learn Sebastian recently immigrated to the United States from Central America. When you ask him about his experience, he just shrugs, does not say much, but starts to talk about his grandmother. So I'd like to know now what questions or additional information you would need to better understand the differences of ADHD and PTSD. And then also I'd like you to look through the diagrams that we've kind of gone through and the different techniques, whether it's the timeline, the ABCs of behavior, the cognitive behavioral triangle, whatever it is that you, or all of them if you want, and to try to develop patterns that you might think might be happening. Okay, so we're going to go into breakout rooms now. You'll work in groups to assess the vignette, and you'll be using the handout that's in the chat, I believe, to look at different behaviors from different perspectives. Some of them, like I said, you'll need to fill in you're on your own or assume, but that's what I just want us to consider, that what the behavior might be telling us and how it could be perceived from a different lens than just one kind of way of looking at it. Okay, so as you all start coming back in, remember to mute yourselves. It was a good break to have a bit of water for myself. So I'd like to just open up into the chat. You know, what came up for you in your breakout rooms? What was that like?
Well, there's definitely lots of more questions than answers here.
Yeah.
But the bottom line that we came up with, based on what we've got here, is that there's probably more PTSD than ADHD, and he very well could have ADHD.
Mm-hmm.
But we felt like the whole cultural stuff, and one thing I talked about was the language. Does this kid even speak English?
Mm.
Or does the kid have an accent? Or, you know, you know, we don't know what he was like in his other school. Was the cartel, did the cartel blow up, you know, a school where he or one of his siblings was at?
Mm. The previous trauma that he may have
Yeah.
come to this country with, right?
Exactly.
There's so much to think about.
Yeah. Is this family homeless? Do they have food insecurity? Is somebody about to be deported in the family? Did he live with his grandmother before?
Mm-hmm.
You know, is that why he brought her up? So
yeah,
those are just
lots of questions, not so much answers, and I think that is the goal of the work, is to understand as much of this as possible, like intersectionally, through all the different behaviors, through all the different things that we're getting, and creating patterns of who this kid is, what is going on for him, what might be happening. So I see a lot of comments in the chat. I'm so glad that you all really thought so comprehensively about this child, because even though this is a vignette, this represents so many children that come through the mental health system that are showing us something. We're not quite sure what that is. And our goal is to really try to understand it as much as possible in a way that gives them the care and the treatment that they need to get back to the baseline that we were talking about. And that's partially why I'm very passionate about this work, making sure that we understand kids. What are they telling us? So it's great that there's so much thought that's been put into this. I did want to take a moment and look at what you thought about particular things in general. So let's start with the timeline. Is there any particular thoughts about the timeline or questions that you had about the timeline, or in terms of understanding? Does it signify more of a PTSD or ADHD presentation? So when did those behaviors start? Is this something that has been ongoing for the child? And even if it was, could we really say, would there be a difference? Because if the child has been exposed to any kind of traumas in his own home country, maybe it's hard to have a baseline of stable functioning for the child. What is he like in different environments, in different settings? Has he been in school? Yeah. So all of these really important questions to ask. And now let's think about the application of the ABC model of behavior. What did you identify as the behavior? And then what possible antecedents or consequences might have come up for that child in that behavior? So someone thought of the behavior of pacing and what that meant, and making sure to look before the pacing and after the pacing, what happens. So in this particular situation, with the pacing and getting out of quiet activities, it looks like one of the consequences that might happen is he gets the attention from a teacher. So maybe, right, someone says that the teacher might make the client feel safe, because then he gets to work one-on-one and feel safer having that one-on-one. Yeah. And now let's think about the CBT triangle. What thoughts, feelings, or behaviors did you identify? And how might that impact the other points of the triangle? That's right. Quiet time could be a trigger, because that is when things are quiet, except for the mind is pretty loud. Okay, so some people considered the feeling of frustration, maybe the feeling of impulsivity. So for these points in the triangle, we'd need to get, the two other points to really have this like complete picture of who this kid is. So maybe he had a strong connection to his grandma. Yeah. So all of these very good points. And these are all things that can be applied when a client comes in with these presentations. So how might you treat this child? Knowing what you know, what certain evidence-based practices might you use? I mean, you could use the ones I talked about, but maybe you have some others. What others might you use? Definitely bullying or other external stressors, racial trauma, bullying. Yes, that could be TFCBT, family therapy. So a lot of TFCBT. CPP, child parent psychotherapy, play therapy, case management, making sure that the child has things that they need. Potential medication, and that's important too. I'm not a medical doctor, so I don't prescribe medications, but anecdotally, I do know that there have been some cases in which medication can impact actually anxiety or trauma symptoms and exacerbate them. So when you are communicating a referral to a psychiatrist or working with a psychiatrist, that you see this presentation that has a bit of both kind of diagnostic impressions, you will want to tell the doctor those nuances of what you're seeing, that you know, you're considering the anxiety related to the move, or the immigration, or you're considering the you know, other symptoms, because it could sometimes exacerbate. Okay, well, I really appreciate you all thinking so comprehensively into this child. And like I said, this child represents a lot of children that we work with. And one of the main, you know, reasons I like to do this work, I like to present things like this, is to help us understand children better, because sometimes they don't have the words, they have the behaviors to explain themselves. And I really appreciate everyone taking the time to comprehensively understand behaviors. And I really hope that you take some of this insight or these techniques into your own practices and continue to really question the behaviors that you're seeing from different lenses.
Great. So thank you so much, Dr. Ferreira. I think, you know, we had some of the questions come in, and I think were answered throughout your presentation and obviously brought to life with this vignette. I do want to remind folks, in the next 2 to 3 days, the slides will be up, as well as the recording. My colleague Vanessa has put in the chat box a survey. So if you could please take the time to fill that out. A very short survey. Again, these do help to frame our future offerings. On this slide here, we have just listed upcoming CTAC events. You can certainly visit our calendar, our webpage, ctacny.org, for upcoming events and to register for these. And again, obviously, towards the very end here, I do want to thank Dr. Ferreira for her wonderful presentation. We are seeing a lot of thank yous coming in. Again, to all of you for joining us. As I mentioned beforehand, the feedback survey that has just again been put in the chat box, please take the time to fill that out. Again, it's very short. And if you have any questions or concerns, please feel free to reach out to us at ctac.info@nyu.edu. On behalf of CTAC and our presenter, we wish you all a great rest of your day. Thank you so much.